Welcome back to the Deep Dive. Today we are tackling a really core clinical issue, one that's had, well, quite a bit of anxiety around it historically. Red blood cell transfusions. For decades, I think the thinking in many places was just, when in doubt, transfuse, better safe than sorry sort of thing.
Yeah, that old dogma.
Yeah.
But it's really being challenged fundamentally by the data we're looking at today.
Okay.
This is the big one, the new comprehensive update of the Cochrane review on transfusion thresholds. We're talking a huge amount of evidence.
So huge.
Get this, 79 unique studies, and they cover 27,639 participants. Monumental.
Right.
It's basically the best statistical answer we have right now to the question, how low can you safely go? Or how much blood is really enough?
Right. That's the gold standard for evidence synthesis.
Yeah.
A Cochrane review of that size. So for anyone maybe less familiar, we absolutely need to define the two main strategies being compared here.
Definitely. It all boils down to this comparison. First up, you've got the restrictive strategy. Think of it as the minimalist approach. Transfusion is generally held back until the patient's hemoglobin, the HB, falls below a pretty low threshold, usually around 7.0, maybe 8.0 grams per deciliter.
Waiting longer, essentially. And the alternative.
That's the liberal strategy. This is more the traditional standard, keep the levels higher.
Right.
So you transfuse patients much earlier, aiming to keep their hemoglobin count up, usually targeting maybe 9.0 or even 10.0 GDL.
Got it. So our mission today is really to dig into this massive data set. Does transfusing earlier, the liberal way, actually give any measurable benefit compared to waiting the restrictive way?
Exactly. Does it affect mortality? What about complications? And crucially, how does the patient actually feel and function afterwards? Quality of life stuff.
Okay, let's unpack this then. Where should we start? Maybe with the most straightforward finding, the amount of blood used.
Yeah, let's start there. Because the impact on blood usage is unambiguous. It's high certainty evidence across the board.
And the winner is?
Restrictive, hands down. It massively reduced how often patients got transfused.
Give us the headline number on that reduction. What are we talking?
Okay, so across all these trials, restrictive practice cut the relative risk of getting at least one RBC transfusion by 42%.
42%.
Yep. The risk ratio was 0.58. Just think about that. Patients in the restrictive groups needed blood roughly half as often.
That is a huge saving, not just for blood banks, which are often strained,
Yeah.
but think about the cost, the resource.
So, absolutely. The economic side is profound. The review actually quantifies it.
Yeah.
Using a restrictive trigger saved, on average, 1.38 units of red blood cells for every participant who ended up needing a transfusion anyway.
Wow. Nearly 1.5 units saved per person. Multiply that across a hospital system.
Yeah, you're talking potentially millions in savings annually, euros, dollars, whatever, plus less donor exposure.
Okay, but here's the crucial question, the one that gives clinicians pause. Mortality. If we're holding back blood, waiting till the HB hits 7, are we putting lives at risk to save blood? What's the big picture on 30-day mortality?
This is really the core finding that shifted practice. And it's fascinating. For the vast majority of adult patients, critical care, cardiac surgery, orthopedics, you name it, there was essentially no difference.
No difference in 30-day mortality.
Pretty much none. The overall risk ratio was right around 1.01, basically parity.
So survival rates are effectively the same whether you transfuse early or wait longer. That must have been the single biggest piece of evidence driving guideline changes worldwide.
Absolutely. It gave clinicians confidence. This similarity in death rates, despite using way fewer blood units, it validates the restrictive approach as safe. Safe for most people.
It tells us the body is actually pretty resilient to mild or moderate anemia in most acute situations. More resilient than we perhaps thought.
Exactly. We gave it less credit than it deserved, maybe.
Okay, so if waiting is generally safe.
Right, this is where the nuance really matters. And yes, there are important exceptions. Let's start with one group where their restrictive wait longer strategy actually showed a potential benefit.
Okay, who's that?
Patients with acute gastrointestinal bleeding, GI bleeds.
Huh, that seems counterintuitive. Someone's actively losing blood, you'd think getting blood in quickly would be key.
That's the old thinking, yeah. But the data here suggests something different. For patients with GI bleeding, their restrictive strategy was linked to a lower risk of dying within 30 days.
Lower risk. How much lower?
The risk ratio was 0.63, which translates to roughly a 37% reduction in mortality risk compared to the liberal group.
Wow. That's a big difference. Why would giving less blood be better for someone bleeding from the gut?
Well, the leading hypothesis, the clinical thinking, is about blood pressure, specifically portal venous pressure. If you transfuse aggressively early on, you might jack up that pressure too quickly.
Ah, and that could dislodge a clot that's trying to form, leading to more bleeding.
Potentially, yeah. Rebleeding is a major issue. So it seems holding back a bit, using that lower restrictive threshold, might actually give the body a better chance to stabilize, clot off, and stop the bleeding for good.
That completely flips the script. Okay, so GI bleeding might favor restriction. What about the other side? Where might that higher liberal threshold actually be needed? You mentioned function earlier.
Exactly. This is where it gets really interesting because the focus shifts a bit from just survival to how well someone recovers. We're talking neurocritical care here.
Okay, like brain injuries.
Yes. The source highlights adults with acute brain injury, think subarachnoid hemorrhage, traumatic brain injury. The data, cautiously, suggests these patients might do better functionally.
Functionally how?
Better ability to walk, take care of themselves later on, better functional outcomes if they maintain higher blood counts through more liberal transfusion.
So the idea is maybe keeping oxygen delivery higher doesn't change the death rate much, but it could protect those recovering brain cells, leading to better long-term independence and quality of life.
That's the thinking. The brain is incredibly sensitive to oxygen. So if a more liberal strategy helps preserve neurological function during recovery, the extra blood might be justified. But, and this is important, the review stresses this is still tentative. More research is really needed on these functional outcomes, not just mortality.
Understood. Okay, another sensitive group, the elderly. Delirium is a huge issue post-op or in critical illness for older adults. Did the review look at that?
It did, specifically. They analyzed delirium in participants aged 65 to 90. And this is a really important finding.
What did they see?
Delirium is a major predictor of bad long-term outcomes, as you said. And among the thousands analyzed for this, the liberal group getting blood earlier to maintain higher levels was favored for avoiding delirium.
So more blood potentially meant less confusion.
That's what the data suggests. The relative risk was 1.18, favoring the liberal strategy for preventing delirium.
That presents a really tricky trade-off, doesn't it? The liberal approach means more blood, more cost, maybe slightly more transfusion reactions, but it might reduce this really detrimental complication in vulnerable older patients.
It absolutely does. It forces a personalized decision.
Yeah.
If you have an elderly patient at high risk for delirium, does the benefit of potentially avoiding that outweigh the downsides of more transfusion? It challenges that one-size-fits-all restrictive approach.
Okay, let's pivot slightly now. Talk about some other nuances. Pediatrics, quality of life measures, maybe alternatives to just using hemoglobin. What about kids? The data must be less extensive there.
That's right. Fewer trials, fewer participants overall. They looked at 8 pediatric trials, about 2,700 kids in total.
And the overall finding, similar to adults.
Broadly, yes. No clear difference in 30-day mortality between restrictive and liberal strategies. But, and it's a big but, the certainty of this evidence is rated as low. Fewer kids in the studies means fewer events, making it harder to be statistically certain.
So restrictive seems okay for kids generally, but we're less sure than we are with adults.
Exactly. And there are hints of complexity. One small trial, for example, suggested a strong benefit for a restrictive threshold, specifically in kids with pediatric pulmonary edema.
Really? How strong?
Like a risk ratio of 0.09. Very striking, though, from a single small study. It just highlights that specific conditions, especially in kids, might need very specific, tailored thresholds. We can't just paint with a broad brush.
Yeah, it really drives home that just using one HB number for everyone, a GI bleeder, a kid with lung issues, someone after hip surgery, it's kind of a blunt tool.
It is. And that brings us nicely to quality of life, or QOL, and fatigue. These are the things patients often care most about day to day. But getting solid answers from this huge review, it's tough.
Why is it so hard? With nearly 28,000 participants, you'd think we know if transfusions make people feel less tired.
It's a massive methodological headache in this kind of research. The meta-analysis for QOL and fatigue is basically labeled uninformative.
Uninformative, why?
Because the studies measured it in wildly different ways. Some used validated questionnaires, others just asked a single question. And they measured it at different times post-transfusion. Trying to pool that data is statistically, well, messy, almost impossible to draw firm conclusions.
So it's not that QOL isn't important, it's just that we haven't figured out a good standard way to measure it reliably across all these different sick patients.
You've got it. You're comparing someone intubated in the ICU with someone recovering from elective surgery. How do you standardize fatigue or well-being across those groups meaningfully? The lack of clear QOL data is actually a key finding about the challenges of acute care research itself.
Were there any glimmers, any signals at all in the noise?
Very faint ones and very cautiously reported. 2 small pilot studies looked specifically at patients with chronic conditions like cancer or hematological malignancies.
Okay, people living with anemia long term.
Right. And in those specific groups, there were hints that a liberal strategy, keeping HB higher, might improve quality of life, potentially reducing that chronic fatigue.
Ah, that makes intuitive sense. If you're dealing with anemia for months or years, not just an acute hit, maybe maintaining a higher level does make a difference to daily energy and function, even if it doesn't change short-term survival in acutely ill patients.
Precisely. It's that difference between just surviving and actually living well. And that whole issue, that dichotomy, is partly why research is trying to move beyond just fixed HB numbers.
Towards more personalized triggers.
Exactly. Some studies are testing alternative ways to decide when to transfuse.
Like what? If not just hemoglobin, what else are they looking at?
Things like physiological scores or real-time measures of oxygen delivery. A good example is using something called central venous oxygen saturation, or SCVO2.
Okay, let's clarify SCVO2 for listeners.
Yeah.
How is that different from just checking the hemoglobin level?
Okay, so hemoglobin tells you how many red blood cells, the oxygen carriers you have. SCVO2 essentially measures the oxygen saturation of the blood coming back to the heart after it's circulated through the body.
So it's measuring how much oxygen the tissues actually used up versus how much was left over.
Pretty much, yeah. It gives you a dynamic picture of the balance between oxygen delivery and oxygen consumption by the tissues. The idea is to base the transfusion decision on actual tissue oxygen need, rather than just the carrier count. More physiological, more personalized.
Right, moving from just counting the delivery trucks, HB, to seeing if the goods are actually being unloaded and used effectively, SCVO2. Is this approach proven to be better yet?
Not yet, no. The evidence is still quite limited. We need more, bigger trials to really know if using SCVO2 or other physiological triggers consistently leads to better outcomes than standard HB thresholds across different patient groups. But it's definitely where the field is heading.
Okay. And finally, we have to talk about the economics. Money and resources are always part of the equation in healthcare decisions. The data here sounds pretty compelling.
Oh, it's incredibly powerful, and it really reinforces the safety findings we discussed earlier. There was one specific trial mentioned, the reality trial, which looked at patients having a heart attack, acute myocardial infarction.
Yeah. What did it find?
It found that the restrictive strategy was, and this is a specific economic term, dominant at 30 days.
Okay, we need to define dominant in this health economics context. What does that mean?
Dominant means it wins on both fronts. First, it saves money. In that trial, it saved around €33,000 for every major adverse cardiac event, or MEE, that was averted.
Wow.
And second, it provided clinical outcomes that were not inferior, basically just as good as the liberal strategy. So it's cheaper and clinically performs just as well.
That's like the holy grail in health economics. Cheaper and works just as well. Makes a restrictive approach a pretty clear winner from a system perspective.
Absolutely. And this cost factor, combined with the safety data, has huge implications, especially in settings outside of wealthy countries.
Right, you mean in low-resource settings.
Exactly. The review makes a strong point here. The evidence strongly supports avoiding liberal transfusion in places where blood might be scarcer, or where the risks associated with the transfusion, like blood-borne infections, might be higher due to less rigorous screening or storage.
So if the survival outcomes are the same with restrictive versus liberal for most people,
then the ethical and logistical choice becomes clear. Use less blood, use the restrictive approach to minimize unnecessary risk and conserve a precious resource.
Okay, so let's try and synthesize all of this. After this massive deep dive, what's the main takeaway for clinicians, for patients right now?
I think the big picture is pretty clear now. The large-scale evidence overwhelmingly supports restrictive thresholds, aiming for that 7 or maybe 8 GDL-HB as being safe and effective for the vast majority of patients in most clinical situations.
And doing so saves a ton of blood, reduces costs, without generally impacting survival.
Correct. That's the baseline.
But it's not rigid. The exceptions matter. The GI bleeder who might do better with restriction, the elderly person where a liberal approach might prevent delirium. Those nuances are critical.
Absolutely critical. The research really suggests practice needs to keep evolving, moving away from just one or two fixed numbers for everyone towards more personalized strategies.
Considering the patient's other illnesses, why they're anemic, maybe those physiological measures we talked about.
Exactly, tailoring the transfusion trigger to the individual's specific situation and risks.
It feels like we've definitively answered the question, is it safe to wait? The answer for most is yes. But the next question, the harder one, is what's the optimal level for this specific person in this specific situation?
You've nailed it. That's the frontier. And think about this. This review found 31 new trials published just since the last update in 2021.
Wow, the field is moving fast.
Incredibly fast. Yet, even with all that, we still have gaps. We lack really robust, large-scale data on some key vulnerable groups like kids with traumatic brain injury or adults with chronic bone marrow failure needing long-term transfusions.
So where does that leave us? What's the next step for research? Does it mean we need totally different kinds of trials?
I think it does. Maybe the next generation of studies needs to be more radical, perhaps platform trials.
Platform trials, you mean testing multiple different thresholds simultaneously within one study?
Yeah, imagine a trial that could efficiently compare, say, a threshold of 7 versus 8 versus 9 versus 10, all within specific patient groups, using adaptive designs to quickly find the optimal zone for different people.
That would let us really zero in on that exact optimal level, maybe even for subgroups we haven't clearly defined yet.
That's the hope. The simple days of just comparing low versus high are probably numbered. The future has to be about smarter, faster, more personalized trials to figure out precisely how much blood is just right for each unique patient. That's the next great challenge, really.